Time to start the webinar today. So good morning, everyone. My name is Dr. Ho Dang Quy Dung from Vietnamese Federation for Endoscopy. It's a great honor to welcome all of you to the AEG workshop, this time on the topic Interventional EUS. And this is the 1.5 day program workshop, and we have the lecture session in this morning. In the afternoon, we will have the hands-on training in model and case demonstration in tomorrow morning. And first of all, I would like to say thank you very much, Dr. Nguyễn Công Long, the director of Digestive Endoscopy Center, for organizing this workshop. I would like to say thanks to AEG and big thanks to Professor Anthony Teoh, Professor Yousuke Nakai for the time giving the lecture today. Thank you all, the doctor, for taking time to join us today, and Olympus company support this workshop. So thank you very much for your joining.
Now we start morning session with the first lecture from Professor Yousuke Nakai on topic EUS BD in Hierarchical structure. Professor Yousuke is now Associate Professor, Department Endoscopy, Surgery, University Tokyo Hospital. He specializes in diagnostic therapy, endoscopy, gastroenterology, oncology, interventional radiology. Welcome, Professor Yousuke, and please start your lecture.
Thank you for your kind introduction. I'm very sorry to not to attend the meeting on site and go to Vietnam due to the COVID-19. Right now in Japan, we are importing from Vietnam so many medical products, and we are running short of some devices. So hopefully COVID-19 will settle down very soon. So I will give two lectures this morning. The first one is about EUS guided biliary drainage for higher biliary stricture. Let me share my slide. Can you see the slides okay?
Yes.
Okay.
Okay.
Thank you. So I will talk about the management of higher biliary stricture first. Basically, most of higher biliary stricture are malignant diseases, and it is difficult to manage those patients with higher malignant biliary obstruction because there are so many tumors causing higher biliary stricture, like a cholangiocarcinoma, gallbladder cancer, and also metastatic lymph nodes from the gastric cancer or colon cancer. And those cancers behave differently depending on the primary sites of cancer. And first, we have to decide the patient can be resectable or not resectable, because if the patient have a malignancy with a resectable diseases, we have to consult surgeons and decide what kind of surgery the patient will have. And if it's unresectable, there are so many choices like plastic stents or metal stents, unilateral drainage, single stent, or 2 stents, 3 stents. And also we can put the stent across the papilla and also above the papilla. So we have to decide those stent placement based on the anatomy. And there are so many studies performed for higher malignant biliary strictures, and they are very focused on the stent patency. But as I discussed later, recently patients survive longer. We have to think about longer clinical outcomes. This is a guideline from the ESGE, and they recommend we have to consider resectability first. Because if the patient have a resectable diseases, as I mentioned before, we have to consider surgical procedures, and we have to consult with surgeons. And the resectability by surgeon are very different from centers to centers. So we have to decide resectability in the high volume centers. So we have to decide resectability first, and they decide drainage area, and we have to consult with surgeons in high volume centers. And if it's unresectable, then we have to decide what kind of drainage we have to perform. And recently, we tried to drain more than half of the total liver volume. Because of this study showed if we drain more than 50% of the liver volume, the patient survives longer. So we have to drain more than a half of the liver, especially in the highly grade hierarchical strictures. So this is a very famous Bismuth type classification. If it's type 1 and type 2, we choose Ercp. And the ESG recommends we should use a PTBD, percutaneous biliary drainage, in the high grade like a type 3 or type 4 drainage. We have to drain both liver, left and the right liver, to achieve more than 50% biliary drainage. However, PTBD has a high complication rate, and also the quality of life decreased because of the external biliary drainage. So recently we choose Ercp more and more, and now EUS guided biliary drainage can be an alternative to PTBD. This is a study, randomized control study from Korea. This is the Ercp study. They put single stent or two stents, both left and liver, in those study. This is a unilateral stent. Put the stent in the right or left liver, or this is a multiple stenting for left and right liver. And they compare the stent patency and also survival. Obviously, bilateral metal stenting has a longer stent patency, and this is a survival. It's not statistically significant, but bilateral stenting has a longer survival. So we have to drain both left and right liver. And this is based on the Bismuth classifications. And this is a stent patency. As you can see, if you put the stent either left or right, the stent patency decreased as the Bismuth classification gets higher, means a high grade higher stricture. But if you put two stents, then stent patency stays more than 200 days. So if the patient has a high grade stricture, then we have to drain both left and right liver. And recently we have a special metal stent for higher biliary stricture. This is a large cell type, and this is a higher stent. There's a white mesh in the center of the stent. By using these specialized stents, it's easy to put the two or three stents in the high grade higher stricture, and we can also perform the intervention by a Ercp using those stents. However, it's technically possible but still it's technically demanding. Sometimes we fail to put the stent through the previously put the stent. So we need a very high skills to perform re-intervention after stent occlusion in those multi-stentings. And we also have to think about the later stage of the patients. If you put bilateral metal stent, in the end, we need a PTBD in the 37% of the patients, and we couldn't remove the PTBD until this. So because of the complex stenting in the hilar area, so we have to think about this. So if we put the 2 or 3 stents in the hilar, in the long term, we may need a PTBD, and we couldn't remove the PTBD tube after bilateral metal stent. So it may decrease the quality of life of the patient in the later stage. And we know EUSBD can be an alternative to PTBD after failed Ercp. In this meta-analysis, PTBD and EUSBD has a comparable technical success rate, and the adverse event rate is lower in the EUSBD. So we are increasingly using a EUSBD for hilar malignant biliary obstruction. And there are some treatment options. We can just put the Hepaticodiodenostomy from the stomach in the left lobe, and we can also bridge left and right liver by putting a metal stent through the EOS HGS route like this. Or we can perform Hepaticodiodenostomy to the right lobe from the duodenum. Or we can combine Ercp stenting like this in the right lobe and put the HGS to drain both left and right liver. This is a study after multi-stenting by Ercp. As you can see, the patient has a metal stent both left and right liver, and when the stents occluded, they couldn't put the guide wire through the mesh, so they performed the EUS HGS from the stomach like this. In this study, using a EUSBD, technical success rate was more than 95%, and the clinical success rate was about 75%, and the adverse event rate was as low as 10%. But we have to remind, this is a report from the very experienced centers. So EUSBD allows biliary access as easy as PTBD, because basically we can do the same procedure from the stomach to the left liver, and the patient will have a better quality of life due to the single session internal drainage as compared to PTBD. And this is another study. This is also from Japan. This is a study of the 180 patients with hilar malignant biliary obstruction who underwent multi-stenting. And during the clinical course, about 30% needed re-intervention because of the stent occlusion. And they tried Ercp first, and the success rate was about 70%, and about 30% patient had failed Ercp. And if they performed EUS re-intervention, the success rate was more than 85%, and the PTBD was necessarily only 4%. So if we can perform EOS guided biliary drainage, we still have a high success rate of endoscopic internal drainage. And this is a comparison of Ercp biliary drainage and the EOS biliary drainage for the re-intervention after multi-stenting. As you can see, ERCP stenting has a short stent patency, and the USBD provides longer stent patency. Because the patient already had a multi-stent in the hilar area, if we put another stent in the hilar region, the stent tends to occur very early. In this study, about 3 months, because if we put the multi-stent across the tumor, the stent clog because of the sludge or bleeding or tumor in the short term. So we prefer EUS guided reintervention, not across the tumor, because of the long stent patency. And this is a summary of EUS guided biliary drainage for hilar malignant biliary obstruction. As you can see, the technical success rate was more than 95%, and the clinical success rate was about 80%. This is a little bit lower compared to the distal malignant biliary obstruction. And the adverse event rate was 88%. This is not so high, so it's acceptable. And in those studies, most studies perform USBD as a rescue procedure using a metal stent. As I mentioned, there are so many options for USBD, like HGS and bridging, and HDS and the combination. And this is a procedure for EUS HGS with a bridging technique. First, we puncture from the stomach to the left B2 or B3, and then put the catheter and put the guide wire through the hilar structure. To pass the structure, we often use a steerable catheter like a swing tip from the Olympus, and the hydrophilic guide wire like a thermo guide wire. And then put the stent across the hilar structure using an uncovered metal stent. Recently, we have a couple of slim delivery stents like Zilga from the Cook or other companies from Korea or Japan. It's very slim, like a 6 Flange or below, so we can pass the structure very easily. And if it's difficult, we can choose the stiff type guide wire, or we can balloon dilate hilar structure if it's necessary. And then finally put the Hepaticodiodenostomy stent to drain the left biliary drainage. And this is the end of the procedure. And sometimes it's difficult to pass the guide wire or devices through the hilar structure because of this kind of angulation. And it may prolong the procedure time. But if it takes too long, there is a risk of bile leakage. So we can just perform EUS HGS in the first session. And then in the next session, we can approach through the HGS stent to the right lobe and put the stent in the second session. So if it's too difficult to pass the guide wire, I will recommend just put the HGS stent in the first session. And the Hepaticodiodenostomy is another option. Like this case, this is an isolated dilation of the right posterior branch. In those patients, we can also perform ERCP and put a stent, but if it's difficult, we can puncture from the duodenum valve to the B6, and then put the guide wire and put the metal stent from the duodenum to the right posterior branch. And this is another option. And this is long-term data after Hepaticodiodenostomy. This is a report from the Korea. They are experts of the Hepaticodiodenostomy, and the technical success rate was more than 95%, and the clinical success rate was again about 80%. And the adverse event rate was slightly higher in the Hepaticodiodenostomy, about 20%. And if you look at the stent patency, it's about 1 year, so it's quite long. And if they compared benign and the malignant structure, and both have a very long stent patency. as you all know, if you put the Ercp stent through the malignant stricture, the stent patency is not as long as like 1 year or so. So if we put the stent not across the tumor, the stent patency may be longer. But there are not so many reports of the Hepaticodiodenostomy. As you can see, the adverse event rate was slightly higher. So we need a special technique to achieve EUS hepaticoduodenostomy safe as hepaticogastrostomy. And this is our case. The patient has a hepatocellular carcinoma. This is a tumor invading into the bile duct. It's very hypervascular. First, we try Ercp. As you can see, there's some bleeding from the ampulla, and we put the catheter and the guide wire. This is the tumor invasion from the hepatocellular carcinoma. And once we put the guide wire and the catheter, there are so many bleeding. Like here, you can see the defects due to the hemophilia in the bile duct, and there are also massive bleeding from the ampulla. So in the first session, we just put the nasobiliary drainage. And after we discuss the patient, because if we put the stent across the tumor, it may cause massive bleeding again. So we decided to perform EUS hepaticoduodenostomy using ENBD tube. We put the contrast and the dilator light into hepatic bile duct, and then we puncture the bile duct from the duodenum valve, and then finally put the stent from the right posterior branch to the duodenum. By using this technique, the hemophilia didn't happen, so the patient, the jaundice recovered. So the patient is now under chemotherapy. And the technical hurdle in the EUS guided hepaticogastrostomy and the hepaticoduodenostomy is to understand the liver anatomy. There are so many reports, but I recommend those 3 papers to understand the liver anatomy. From the stomach, it's relatively easy. You can visualize left hepatic vein. If the bile duct or liver is closer to left hepatic vein, it's a segment 2 or bile duct 2. And if it's underneath the left hepatic vein, it's a segment 3 or bile duct 3. But from the duodenum, to understand the liver anatomy is a little bit difficult. I usually use a portal vein as a landmark and visualize the bile duct around the portal vein. So when we perform EUS guided hepaticoduodenostomy, we prefer posterior branch like a B6, and then go to the central area. And finally, I will talk about the combined Ercp and the EUS guided biliary drainage. We can put a metal stent to the right biliary drainage, and then perform EUS guided hepaticogastrostomy. And if we fail Ercp, then we can also perform hepaticogastrostomy and the hepaticoduodenostomy. And this is a report from the Professor Konkam from Thailand. If the patient came to the endoscopy unit, they perform combined Ercp and the EUS biliary drainage technique. And if the patient went to the radiology unit, then radiologists perform the PTBD, and they compare these two strategies. As you can see, most of the patients of combined Ercp and the EUS BD group, they prefer Ercp to the right as a right biliary drainage and put the EUS hepaticogastrostomy, because in most centers we have a lot of experience of EUS guided hepaticogastrostomy we can safely perform this procedure as compared to EUS guided Hepaticodiodenostomy. In the technical success rate, PTBD was 100%, and the combination of Ercp and EUSBD is about 84%. And the clinical success rate was both around 80%. However, if you see the stent patency, obviously recurrent biliary obstruction rate was higher in PTBD. And the EUS and the Ercp drainage has a longer time to recurrent biliary obstruction. So as a stent patency, I think here endoscopic approach is better than PTBD. This is a very recent report guideline from ESG, which is published just last month. And they suggest EUSBD when we failed ERCP or PTBD in high volume centers. But there are not so many reports, so it's just weekly recommended. This is my strategy. If the patient has unresectable hilar malignant biliary obstruction and duodenal invasion, we prefer EUS guided hepaticogastroscopy and bleaching. And if it's isolated left or right intrahepatic bile duct dilation, then we can perform EUS HGS or HDS, or we can also perform ERCP. And if it's high-grade malignant biliary obstruction, we try ERCP first. And if we failed, we can combine with the EUS guided hepaticogastroscopy. And after bilateral stenting, if the stent occluded, we prefer EUSBD for re-intervention recently. As you can see, we can put multiple metal stent by ERCP and also EUSBD like B3 HGS and B2 HGS. So we can achieve complete drainage by a combination of ERCP and the EUSBD. And this is my last slide. ERCP, especially the intervention after multi-stenting, is technically demanding, and we can perform EUSBD as a treatment option as a primary or re-intervention. However, we don't know which is the best strategy, combination of ERCP, EUS, or just EUS alone. We should clarify in the future. And I must say, EUSBD for hilar structure is technically difficult. We need knowledge, techniques, and experience of ERCP and EUSBD. And I cannot recommend EUS guided biliary drainage for hilar structure as an introduction of EUSBD. First, we have to perform EUSBD for distal structure because it's technically easier. And then after that, we should perform EUSBD in those patients. Thank you for your kind attention.
Thank you, Dr. Yousuke, for your excellent lecture. We will have discussion session later. Now we will move on second lecture about the EUS Fna FNB helper, Professor Yousuke as well. But Professor Yousuke, please continue your second lecture.
Okay, thank you. So I will next talk about the EUS guided Fna. This was developed about 30 years ago, 1992, 1994. This is a very first report of EUS Fna for pancreatic lesions. And this is a meta-analysis of EUS guided Fna for pancreatic solid lesion. The sensitivity was more than 90%, and we must reach this number to perform EUS Fna for the patients. This is adverse event of EUS Fna. You can see in the prospective studies, for pancreatic lesion, it's about 2%. If you puncture cyst, it's about 5%. And most of the complications are just pain or pancreatitis or bleeding. We have to consider about these complications. And there are so many factors to perform EUS Fna, like suction, stylet, number of passes, and the needle size. And this is most important. If you can detect and puncture by the needle, you can get specimen, I think, more than 19 or 95%. So we have to master EOS visualization. And I have to say in one hand to perform FNA, and we have to choose, we have to free your right hand to perform FNA. So first, you have to learn EOS visualization, and then you can perform EOS FNA very easily. When we perform EGD and colonoscopy, we use the right hand to manipulate the scope. But for EOS FNA, the left hand is most important. This is a training. As you can see, the left hand moves from left side to the right side. But for the expert, it's a very small movement. The scope is always in front of your chest. This is quite important to perform FNA or interventional EUS. Put the left hand in front of your chest and put the scope against the table or your belly to stabilize the scope, and then use your left hand to visualize the pancreas or the lesions. And if it's difficult, you can ask your assistant to hold your scope. You have to free your right hand to perform EOS FNA. This is most important. I don't know in Vietnam, but in Japan or other countries, right now we are using FNAB needles more and more. There are so many needles recently. But as we all know, EOS FNA is good enough for the diagnosis of cancer. So by using FNAB, you cannot increase the diagnostic accuracy in the pancreatic lesions. However, sometimes we need a large chunk of tissue, like in pancreatic cancer, and if it's undetectable, we may need a genome profiling in the future. So we choose FNB needles. And in cases with autoimmune pancreatitis, sometimes we need a histological core to get a diagnosis of AIP. We may need a large gauge needle or FNB needle. So we have to think about why you are performing EOS FNA or FNB and choose the right needle. As you can see, if you use FNB needle, you can get this kind of big chunk of tissue and perform genome profiling. This is a DNA amount in the pancreatic tissue. As you can see, obviously, if you choose FNB needles, you can get more DNA. This is a comparison of 25 gauge FNA needle and the 19 gauge and 22 gauge FNB needle for pancreatic cancer patients. As you can see, the diagnosis was obtained both in FNA, small FNA needle, and the large FNB needles. But if you want to perform genome profiling, this is a foundation one, commercially available one. You can see FNB needle can get adequate tissue for genome profiling. So right now, for pancreatic cancer patients, we always choose FNB needle, like 22 or even 19 gauge needle. And this is a subepithelial lesions. If you choose FNA needle, again, sometimes we need this kind of immunohistochemical staining. FNA, the sensitivity of FNA was about 50%, but if you choose FNB needles, it's about 80%. So we should choose FNB needles. And how many passes do we perform? In the past, we need to perform 7 passes. It's reported in 2004 because the needle was not as good as right now. And more recently, if the lesion is more than 2 cm, we need 4 passes. If it's smaller, then we need 6 passes. But if you choose 22 gauge Francine FNB needle, I think for pancreatic solid lesion, 2 passes was enough. This is the FNB and this is FNA. If you choose FNA needle, you may need 4 passes. But if you choose FNB needle, 2 passes was enough to get that specimen. And if you choose FNA needle, you cannot tell by looking at the specimen with your eyes. And you may need a Lowe's rapid on-site evaluation by a microscopical examination. And this is a report comparing FNA with Lowe's and FNB with Lowe's. As you can see, if you use Lowe's, the number of passes decrease in the FNA group, but with the FNB group, the needle path was similar. So if you choose EUS FNB needle, you may not need rapid on-site evaluation. And this is a recent randomized control trial comparing FNB with Lowe's and without Lowe's. If you choose FNB needles, you don't need a rapid on-site evaluation to get a high accuracy, and both technique has a tissue cover, but FNB alone was higher. So recently we don't ask FNB, if we choose FNB, we don't ask Lowe's routinely recently. And this is another technique for evaluation of the FNA specimen, because in many centers, Lowe's is not always available. This is a macroscopic on-site evaluation. And this is a specimen of FNA. You can see the blood, but you cannot see the obvious tissue. But if you choose FNB needle, sometimes we can get this kind of long white core, so we can tell it's good enough. This is a study performed in the Asian EUS group. This is the most. If you see these white tissue more than 4 millimeter, then you can stop the procedure. And then they get similar diagnostic yield with less number of passes. So if you don't have Lowe's, then you can choose FNB needle and check the specimen. And if you see this white core, then you can stop the procedure. And the fanning technique is also important technique. You can move the needle within the lesion, like this case, puncture in the center first, and then change the needle angle like this. I will show you the short video. Puncture first, and then stroke in this area. And then by using the elevator or scope angle, we can change the angle to the different side, like this. So this is important because if the center is necrotic, we may want to puncture this area to get the tumor tissue. So if you can, you should perform this fanning technique every time. And there are so many needles recently, and we don't know which needle is the best needle. This is a study from the US. They compared 4 needles, Procor, EG Shot 3, Acquire, and Charcoal. And they also compare suction technique. Suction and stylet retraction or slope and no suction. And there are so many variables, but in the end, the best needle is a Francine or fork tip needle for pancreatic lesion. And the suction is not always necessary. We can use a slope technique like this picture as performing the FNA. The assistant can slowly pull the stylet to achieve the slightly negative suction to prevent bleeding. But so we should have our own clinical practice. My preference is a 22 gauge Francine needle and 10 cc suction first. And if the specimen is bloody, then in the next puncture, we use no suction or started slope. And we perform 2 to 3 passes and without lows, and we always use fanning technique to puncture the different side. And mostly we can get a good result of EUS Fna or Fnb. I will talk about biliary stricture shortly. There are two options, Ercp, biopsy or brushing, or EUS Fna. If you compare EUS Fna and the Ercp, in the report, the sensitivity was higher in EUS Fna. However, we must consider the nature of the stricture. If it's intrinsic stricture like cholangiocarcinoma, we should perform Ercp. But if it's extrinsic like pancreatic cancer obstruction or lymph node metastasis, we may prefer EUS Fna. This is a report from the Korea. They perform Ercp first because anyway the patient is biliary stenting. They perform Ercp first and the Ercp guided tissue acquisition. If it's extrinsic, the accuracy was not as high as intrinsic. And if it's negative, they perform Ercp again for intrinsic stricture, cholangiocarcinoma. It's about 84%, but they choose EUS Fna for extrinsic stricture due to pancreatic lesion or lymph node lesion. Then the accuracy was as high as 90%. And if they combined, it's more than 95%. So we must evaluate CT or EUS before Ercp to choose the appropriate tissue acquisition procedure, Ercp or EUS. So if it's a hilar stricture or intrinsic stricture, Ercp first. And if it's distal, they are mostly pancreatic lesion. So we should perform EUS Fna first. And if it's negative, then what should we do? Sometimes we cannot puncture because of the location or size of the lesion. Then we can change the needle like a small needle or sharp tip needle. And if you cannot get much cellularity, then you can apply more suction, or you can choose FNB needle or bigger needle. And if the specimen is too bloody to make a diagnosis, then we can reduce the suction like no suction or slow pull technique. And if you cannot, if you get specimen, but the pathologists say there are no tumor cells, then we should re-evaluate CT and choose the right target. And we can also apply fanning technique to get the tumor cells. And if you don't know why, then I think you should refer to the expert of EUS Fna. And we should know there is always a risk of false negative. This is a report from the large high volume centers. If the pancreatic lesion was more than 2 cm, the sensitivity was higher than 90%, but the lesion gets smaller, like if it's less than 1 cm, the sensitivity was about 73%. So there's always a risk of false negative. So even if you get negative results in the first session, if the lesion looks malignant, then you should repeat EUS Fna or other diagnostic modalities. And if it's negative in the first session, you should choose a LOS, rapid on-site evaluation, because in the second session, if you evaluate with a LOS, the sensitivity gets higher. So in those special situations, you should consider asking the pathologist to evaluate during the procedure. This is my last slide. I think this is the most important part for the beginners. We should handle EUS scope by left hand alone and use the right hand for FNA. And find your routine technique. As I mentioned, my practice is 22 gauge FNB needle, 10 suction first, and 2 to 3 passes. And if it's challenging, then you can modify your technique, like a smaller gauge needle or apply less suction or such kind of procedure. And you must choose the right needle, FNA or FNB, small or large needle, based on why you need tissue. And there is always a risk of false negative. So we should repeat EUS FNA or that technique if it's negative when you think it's clinically malignant. Thank you for your kind attention.
So thank you very much, Professor Yousuke, for your very informative lecture.
Thank you.
And now we move to the final lecture, EUS guide fluid collection drainage from Professor Anthony Teoh. Professor Teoh is currently Deputy Director of Endoscopy and Associate Professor in the Chinese University of Hong Kong. His research interests are advanced EUS and Ercp. And he played very important roles at the faculty in many AEG training events. Thank you very much for your joining, Professor Antonio Teoh. Please start your lecture.
So, hello, thank you, Professor Dong, for your very kind introduction. So, good morning, everyone. So good to see you here virtually. So today I'll be talking about EUS guided pancreatic fluid collections drainage. So for this kind of procedure, it's probably one of the first EUS interventions that you will learn. And it will be a common intervention, common indication for EUS guided intervention. And also it's a good basis for you to develop other techniques of EUS guided intervention. These are my disclosures. So actually the idea of performing endoscopic drainage of pancreatic fluid collections has been around since a long time ago. In fact, the first case report was in 1975. Of course, at that time, the type of devices and instruments we used was still very primitive. And at that time, EUS was also not available. So actually, the first description was only an endoscopic aspiration. So the endoscopist saw a bulge in the stomach, and they put a needle through the stomach into the bulge and try to aspirate all the fluid out. Of course, with this technique, we know now that actually it's not useful for treatment, and actually the patient has not much pain relief, and also the cysts recur very quickly. But it marks the very first attempt of an endoscopic treatment of pancreatic fluid collections. Since then, we have seen a big development, progressive development in terms of the type of endoscopic interventions for PFC. Initially, in the early 90s, a lot of these procedures were performed blindly by OGD guided nasocystic catheter insertion. And as EUS became more and more popular, a EUS guided approach was adopted because it allows us to see more precisely how the needle punctures the lesion, and also allows us to see intervening blood vessels between the two areas. Afterwards, we became more and more aggressive, and starting we are performing to do more therapy in these type of collections. So there's a description of a one-step EUS guided drainage followed by nasocystic drain irrigation, and also necrosectomy, and more recently, the adoption of metal stents in placement of these collections, and also new devices coming out for necrosectomy. So one thing that we need to be aware of is the kind of collection that we are treating. So according to the acute pancreatitis working group, in patients with less than 4 weeks onset of pancreatitis, if there are fluid collections or necrosis, then they are termed acute fluid collection and acute pancreatic necrosis. And only after 4 weeks, then these collections can be termed as a pseudocyst, either sterile infected or a ward-off necrosis. So in theory, we usually offer drainage after 4 weeks onset of pancreatitis, because only after 4 weeks that there is a well circumscribed wall of these collections, and it becomes safe for EOS guided drainage, because if there's not a well circumscribed wall, then there's a risk of free perforation. But having said that, 4 weeks is a arbitrary number. Sometimes if the patient is very septic, or if there's a wall that formed earlier than 4 weeks, we can also consider earlier drainage. But in the general rule of thumb is 4 weeks onset. After 4 weeks onset, we will perform a wall is well formed, and we can perform EOS guided drainage. Also, a very important distinction between pseudocysts and wall-off necrosis. So pseudocysts is mostly fluid. Around 99% of the collection is like fluid. With wall-off necrosis, there is some solid component inside the collection, and it means that the solid component may need further treatment and may not resolve only by EOS guided drainage. So if you look at this large series by Virajulu, the treatment success rate for pseudocysts, just a pure fluid, is 93% versus 63% in wall-off necrosis. Complication, again, is higher for wall-off necrosis, and reinterventions will be more, and length of stay is also longer. So meaning that in general, pseudocyst drainage, if treated by EOS guided intervention, has a very good outcome. But if you are treating patients with wall-off necrosis, then you need to think more in terms of subsequent management. So drainage is only the first step for wall-off necrosis. So as we know, there are several modalities that we can use to drain these collections. In the past, OGD was suggested, but it was noted that with only OGD guided puncture, there's a risk of arterial injury and uncontrolled bleeding. In some pseudocysts, where there's a clear connection with the pancreatic duct, people have described the use of a ERCP guided PD drainage. So you insert a stent from the papilla to inside the collection via the ERCP approach. And in terms of surgery, it's the traditional either laparoscopic or open cystogastroscopy. And recently, I think EOS has been shown to be gaining more popularity in terms of the preferred type of drainage. So this is a guideline that we published a few years ago. It was the first guideline on interventional EUS procedures. And apart from pseudocysts, we also looked at biliary drainage, pancreatic duct drainage, as well as celiac plexus ablation. Also from our friends, Nakai and also Isayama Sensei, they have published a consensus statement for wall-off necrosis. So wall-off necrosis is a much more controversial area. And but in this consensus, they look at from diagnosis to management to details of endoscopic interventions. So in the AEG consensus statements, we looked at various areas from indication optimal approach, pre-drainage evaluation, pre-procedure preparations, and then also procedural considerations, adjunctive treatments, and also management of complications. So in general, pseudocysts for drainage, usually 4 to 6 weeks. And if they are symptomatic or larger than 6 centimeters in size, we suggest drainage. In terms of optimal approach, the evidence is suggesting EOS guided drainage is the optimal drainage method that are located close to the stomach. Pre-procedurally, we will perform either a CT scan or Mrcp. If you have a multidisciplinary team, then it's useful to discuss with your endoscopists as well as IR people and surgeons on how to treat these patients. Usually we give 1 dose of prophylactic antibiotics to the patient and then continue after the procedure around 5 to 7 days, because infection is the most common complication after pseudocyst drainage. The use of fluoroscopy gives you another dimension for drainage. Certainly you can perform this with a only EOS guided approach, particularly with the use of the lumen opposing stent. If you are using the plastic stent, so then usually we will still need like fluoroscopy. For pseudocysts, I think plastic pigtail stent is still the standard. Certainly you can use a metal stent, but it is much more expensive and you need to remove it before 4 weeks for metal stents. And in patients with a disruption of the pancreatic duct, either a broken PD in the middle with a isolated pancreatic tail, or if there is any pancreatic duct disruption, the risk of recurrence is higher. In patients where they can see an obvious leak in the PD, particularly on the Mrcp, then you can consider a PD stent. And in patients with infected pseudocysts, you can put in a nasocystic catheter to irrigate or aspirate the pseudocysts. And in terms of complications, then definitely you would need a multidisciplinary approach. In terms of training, we think that if you know Ercp, it is beneficial because a lot of the techniques like exchange of guide wire, use of stents are very similar to Ercp. And if you know Ercp, then maybe performance of 5 to 10 supervised procedures should be enough for you to gain competency. So for pseudocysts, it's a little bit more simple, but for warm necrosis, it's more complicated because drainage is only the first step. And very often these patients may be quite septic and they are admitted to the intensive care unit. So your ICU colleagues may be pushing you to do something. But if it's too early, then an EOS drainage may not be possible. Then you may need to consider other types of drainage like percutaneous. And after drainage, there is always the need to consider a necrosectomy. So again, there are various options, including endoscopic, percutaneous, or even surgical. And in terms of adjunctive measures, these patients will more often require some irrigation or even nasocystic catheters for irrigation, and also sometimes necrosectomy. So for percutaneous and transgastric methods, I think both are quite effective. If the collection is more towards the tail of pancreas or even around the parietal gutter, then these patients will be more suited for percutaneous drainage. For many patients, the transgastric method is very useful, particularly for collections close to the body of the pancreas. For a percutaneous method, if you do any interventions, actually, you can just give patients some sedation, and you don't need to go through the mouth. For a transgastric necrosectomy, these usually takes quite a long time, so you might need to perform it under general anesthesia. So this is the landmark trial comparing step-up approach versus open necrosectomy for necrotizing pancreatitis. So they randomized patients in either a step-up endoscopic approach, either percutaneous drainage or transgastric drainage versus a surgical approach. So with the step-up approach, the percentage of patients suffering from major complications or death was significantly less than the open approach. The presence of new onset multi-organ failure is again significantly less. Incisional hernias, new onset diabetes, and also new ICU admission also significantly less in the step-up approach. So in the past, when I was still being a trainee, we used to do some open necrosectomy. And when we do it, once we open up the abdomen, we need to go in once every few days to remove all the necrotic material. And sometimes we have to fashion a zipper in the tummy to allow us to have repeated access. And then this trial compared a percutaneous versus a transgastric step-up approach. So a transgastric approach is via the stomach, from stomach to here, whereas the surgical step-up is a left retroperitoneal approach. So a small incision open over the left side, followed by removal of all this necrotic material, detention trial. So in terms of the primary outcome, composite major complications, there was no significant difference between the two approaches. With the endoscopic approach, there was lower incidence of pancreatic fistula. So a connection between the stomach and the pancreas will slowly close down after the procedure, and you will not end up with an external fistula. Whereas with the retroperitoneal approach, sometimes there's a persistent leak from the PD, and these tends to linger on for a longer period of times. And as a result, the hospital stay would be longer, and also cost of treatment will be higher. So right now, most of the endoscopy units are practicing an endoscopic step-up approach. So after drainage, if the patient still has persistent fever, then we would need to perform a repeat OGD, because sometimes the solid material would be obstructing the lumen of the stent. Then, if there is persistent sepsis, we will insert a nasocystic catheter, followed by necrosectomy. And in general, the stent will be removed after 4 to 8 weeks after the necrotic cavity is cleared of necrotic material. So right now, also after during drainage, we will try to assess the severity of the necrotic material. If there is only a very small amount, then drainage alone is adequate. If there is some drainage solid material, we will schedule a follow-up EGD plus or minus necrosectomy around 1 to 2 weeks time. And if there's a lot of necrotic material, these patients are usually sicker, then we will need to insert a nasocystic drain followed by repeated necrosectomy. And anyways, these patients often will be inpatient for long periods of time. So in terms of techniques, we can drain these collections either via a transgastric or transduodenal, and sometimes transesophageal approach, although this is uncommon. Usually we drain from the area where there's less amount of tissue between the two organs, either from the stomach or the duodenum. Sometimes these patients have a portal vein thrombosis and resulting in a lot of gastric varices. So there will be a lot of intervening vessels. And as a result, we need to assess them. And of course, the angulation of the endoscope. So in the past, someone have compared either the conventional linear echo endoscope versus a forward viewing echo endoscope. I think most of us are used to doing this procedure with a linear echo endoscope at the angle. So the postulated benefit of a forward viewing scope is that the needle is going perpendicular to the collection. So perhaps the force of transmission is more direct, but I think studies have shown that actually both are equally effective, and it really depends on your endoscopist preference. But I think most endoscopists would be accustomed to performing a linear echoendoscope drainage. In terms of stents, now in the past we used to use a lot of plastic stents. Now we have many more options, including regular SAMs or even lumen opposing stents. For lumen opposing stent, the main benefit is that these can be performed with a single step manner. So you can do a direct puncture followed by stent placement in a single step. With the conventional plastic stent placement, it's a multi-step procedure. So you need to puncture, put in a wire, dilate the tract with a cystotome, followed by a balloon, and then insert the stent. So these are the things that you need to consider: the choice of needle, wire, methods of dilatation, and choice of stents. The choice of needle, nowadays, everyone would choose a 19 gauge needle. Usually a nitinol needle is preferred because it is more malleable. The Giovannini needle and the Navix needle system have been described, but nowadays I think most would use the 19 gauge nitinol needle. The access needle is a needle where the tip, the stylet, form parts of the stylet is sharp. So once you remove the stylet, the sharp part of the needle is gone. And it claims that with the access needle, you can reduce the wire shearing, but actually this is not really true. So most of the time we will use a 19 gauge nitinol needle. In terms of wire, we can have the choice of 035 or 025. I think for PFCs, both are okay. If you plan to place a plastic stent, generally we will place 2. Then you will need to use a double wire technique. So after puncturing the needle, you need to insert a wire, pull out the needle, insert a cystotome to dilate the tract, followed by a balloon to further dilate up to 4 millimeters. Or if you plan to insert 2 stents, up to 8 to 10 millimeters. And then you need to change to either a 10 French catheter to insert 2 wires, or use a loop wire, which is, there's a loop on the tip of the wire. You can push it along the initial wire to have 2 wires. In terms of dilatation method, most endoscopists will first use a cystotome, which is a 6 French cystotome. If you don't have a 6 French cystotome, then you can also use a needle knife. But you need to be careful with the needle knife because it might cause perforation. The balloon, if you don't have a cystotome, sometimes you can also insert a balloon out on the wire, but sometimes it may not be possible because of the gastric side. It may be quite tight around the wire. And in terms of dilatation, after insertion of balloon, it depends on how many stents you plan to insert. So if it's just 2 plastic stents, usually the first one needs to be 8.5 French, and the second one you can be either 8.5 or 10 French. So you would need at least around 8 millimeters to 10 millimeters for 2 stents, or if you plan to insert 3, then you will need to be around 10 millimeters. So this is a patient with 8 centimeter pseudocysts in the tail of the pancreas. So this is an older EUS image. So here is the area with the least intervening vessels. So we first puncture with the needle. And then we place a 1 guide wire inside. Next, we use a cystotome followed by a dilatation of tract with a CRE balloon. This was up to 10 because I was planning to insert 3 plastic stents. And then we need to insert 2 wires. So it was already done here, 2 wires, you can see. So for the first wire, I inserted a straight stent. But I think if you plan to insert 2 plastic stent, you can insert a double pigtail. This is the second plastic stent being inserted. And for security, I inserted 1 more. So if you insert 1 more stent, then you need to cannulate the tract. Sometimes it's difficult to cannulate the tract because it might be an angulation. And this is what it looks like after placement of the 3 stents. So in general, 2 should be enough because with 1 stent, sometimes the stent becomes blocked and it may cause an infection of the collection. So this is the CT scan after the drainage and removal of the stent. So in terms of plastic stents, we prefer at least 2. And if you insert 2 stents, you need to put in 2 wires after your initial puncture. But recently we have seen more and more description of the use of metal stents because for the use of metal stents, apart from drainage, we can also use it to enter into the collection, particularly for the water necrosis. And we can insert multiple devices like a nasocystic catheter into the collection for irrigation. So these are the more common metal stents. This one, the Nagi stent and the Pfc stent are both from Taiwan. The axial stent is from Boston. More recently, there are 2 other lumen opposing stents. One is from Hanoi, one is from Mrcp, the Hanoi stents, and another one is from Microtech, the drainage stent. So these stents have some similar design characteristics. They have a large lumen. They are short, sometimes 1 centimeter, sometimes 2 centimeters. For the Nagi stent, you can see the flange, although it's slightly slanted, I won't consider this as a lumen opposing stent because the lumen opposing force is very small. But for PFC, actually, you don't need a lumen opposing stent because the risk of my stent migration is actually very low. So the axial stent, you can see this is more of a dumbbell-shaped size stent. The lumen opposing force is much higher for axials, but it has a very special design, which is a operator controlled deployment. The size largest is 20, and for PFC, I think generally we insert a 15 or 20 millimeters. The length is now 10 millimeters or 50 millimeters. But the main problem is this is extremely expensive. So the Pfc stent has a design where the stent fold on itself after deployment. So this distance is variable. So if there's a lot of tissue, then it may not compress all the way to the final distance, which is around 8 millimeters. So again, Pfc has variable sizes from 16 to smaller sizes. The interflange distance is 8, but the distance between the 2 ends is actually around 2 to 3 centimeters. So if there are more tissue, you can still deploy this stent, and it will not contract up to 8 millimeters. So the deployment system is the usual metal stent deployment system that we use. So the main advantage of the luminal pulsing stent is that it allows a single step delivery deployment. So as I mentioned just now, there are many steps. So we need to insert a 19 gauge needle, followed by insertion wire, track dilatation with cystotome, followed by balloon, and then stent deployment. But with the single step device, you can use just one step. Use this device to puncture, pass the wire, and open the stent. And so this significantly reduces the procedural time, as well as making it much more easier for beginners to learn the procedure. So this is a multi-step procedure. This was done with a forward viewing scope. You can see the angle of the ultrasound is limited. And a Nagi stent was placed. First, puncture the collection, followed by insertion of the guide wire. This is a cystotome. This was a 8.5 French cystotome. So why did I use 8.5 French? Because with this 8.5 French, I can directly insert the delivery system, so without the need of the balloon. But you can see sometimes a larger diameter cystotome does not go through the tissue so well. Followed by balloon dilatation. And then insertion of the metal stent. So this was a Nagi stent. So a lot of dirty material being drained out. And with the hot axios, you can do a direct puncture, followed by opening of the stent. Opening of distal flange, followed by opening of the proximal flange. And then complete deployment. So with all these, this is another one, which is a hot spexus. Again, we can perform direct puncture. Puncture with the device, insert the wire at the same time. Open the stent. And then you can see the flange here. We pull back the stent to a post 2 lumen. Then deploy the stent in the channel and then push out the stent from the channel. So with all these large size luminal pulsing stent, we can perform intervention. So with the stent in situ, we can perform endoscopic necrosectomy. And the stent can be placed in situ, and then we don't need to remove the stent. So in the past, when we use plastic stents for water necrosis, then we need to remove 1 or 2 plastic stents and then dilate the tract, followed by the necrosectomy, and then reinsert the stent again afterwards. Okay, so all these metal stents have the benefit of providing large diameter access for the insertion of the endoscope and performing necrosectomy. So, however, does the evidence support the use of metal stents? If you look at this trial from Siam, first, I think they were in the learning curve of using luminal pulsing stent because they had to change the protocol after recruitment because they had a lot of complications. After changing the protocol, they stopped seeing all these complications. But in the trial, they only were able to show that the procedural duration was shorter in the LAMS group. More additional training tracks were required in the plastic stent group, but the complications were higher in the LAMS group. 3 was severe bleeding, 2 with buried stent syndrome, 1 was biliary stricture. So it might be quite alarming just looking at this outcome. For bleeding, I think it's because the stent were placed for too long. So generally, we suggest removal of the metal stent within 4 weeks. For buried stent syndrome, it's really a technical issue. So as the collection collapses, it will pull the stent away from the stomach. So when we drain, we need to be aware where to drain and also how the collection will collapse with time. So this is buried stent syndrome, where the stent was being pulled out of the stomach. And in this case, even the entire stent cannot be seen. And this is because as the collection collapses, it will pull the stent away from the stomach. So we try to drain as distal as possible. These are pseudoaneurysms where the stent was placed for too long, and perhaps the edge of the stent may be rubbing on a blood vessel. And this is another study showing that if you place the lamps for too long, there's increased incidence of pseudoaneurysm. So as a result, for pseudocysts, I think in general, we suggest the use of plastic stent. For water necrosis, after complete necrosectomy, we place a stent for around 4 weeks, and then we change to either a plastic stent for longer period of time, or we just remove the lamps altogether. So with this most recent study published by our center on the use of Pfc for drainage and necrosectomy, actually, if you look at the bleeding rate, the overall rate is around 5.1% for both pseudocysts and wall-off necrosis. Actually, so it's not that high. So with careful use, that actually, I think metal stents are okay for wall-off necrosis. So for the last bit, I'm going to talk about the adjunctive measures. Transcystic catheters. So usually, if the patient has a very contaminated collection, very big collection, if they are septic in the ICU, then we can insert a nasal transcystic catheter, irrigate 1 to 2 liters of saline per day. There is some description of the use of H2O2 irrigation. Personally, I don't use it because from my surgical background, we have done a lot of studies comparing saline and H2O2, so not much benefit of H2O2, but certainly some endoscopists like it. Role of ERCP. In some patients with recurrent pseudocysts, I would perform ERCP to check if the PD is leaking. And in some patients, if we have a pre-procedure MRCP showing a pancreatic leak, then we can perform a ERCP with PD stenting. So 2 studies describe the use of transcystic catheters with solid debris. The one from Siddiqui noted a better resolution rate with nasocystic catheters. The study from Dr. Piri, again showing a high success rate. So for us, when we use a transcystic catheter, we won't use such a small catheter. We will use a nasogastric tube, insert all the way through the stent into the collection for irrigation and aspiration. And sometimes we can aspirate, we were able to aspirate some solid material as well. So you can see this patient, many drains, ICU patient, 2 plastic stents, 3 plastic stents in the collection, and also a nasal cystic catheter. So this is an NG tube inserted through a metal stent into the collection. For PD stenting, again, if there's a PD leak on follow-up MRCP, then we will perform a PD stenting. Okay, so in conclusion, pancreatic fluid collections, water necrosis are more complex. Multidisciplinary management is sometimes needed, but endoscopic management is definitely now the standard in many units, and this can help the patient recover faster and also reduce morbidity. So thank you for your attention.
So thank you very much, Professor Teoh. So it's time to, we have the 30 minutes for discussion. On the audience, if you have any question, please write down in the Q&A chat box.
Thank you very much for interesting lecture from the Professor Teoh. I have one question. When do you drainage pseudocysts by methane stent? When you remove it?
So usually for pseudocysts, for example, after drainage, we will perform a CT scan maybe 1 or 2 months later. If the collection is completely resolved, then we can consider removal of the plastic stent. For water necrosis, if all the solid component has been cleared, we'll perform a follow-up CT scan around 4 weeks' time. And if the collection is resolved, then we would remove the metal or plastic stent.
Thank you. Some cases have fluid collection far from the GI wall. Some doctors perform the percutaneous by esophagus stent to remove necrosis. Your opinion about it?
Yeah, if the collection is in the paracolic gutter on the side or sometimes in the pelvis, then yes, we would perform a percutaneous drainage as well. If there are some solid component, yes, you can perform a percutaneous necrosectomy. I don't use a stent because I'm a surgeon. So actually, if with a percutaneous catheter, we can open a small skin incision and then tie the track up either with our fingers or some balloon, and we insert the endoscope percutaneously to the collection.
Thank you.
So in pancreatic pseudocyst, you prefer to use the plastic stent, and how many stents usually you use?
If there is mainly just a liquid component, not much solid, then I will use a plastic stent. So at least 2 double pigtail plastic stents.
Yeah.
How about Nakai? What is your practice, Nakai? Is it similar?
Yeah, for the pseudocyst, we use a plastic stent and maybe 2 stents and 1 external drainage for a few days, and then remove it.
So I think in the chat box there are some questions. There's one from Haphazard. So do I ever use a multi-gated approach when managing ward-off necrosis? Actually, I don't use a multi-gated approach. So I think Shyam is a big believer in a multi-gated approach. But for us, I think just 1 drainage site is adequate. And most importantly is to clean the cavity thoroughly. Nakai, do you use a multi-gated approach?
Yeah, I sometimes use it, but it's because once you put axios or some lamps, sometimes you cannot put the scope because of the narrow lumen. Then we put another port for the necrosectomy.
Okay. So just mainly for access.
Yeah.
There's a question for you, Nakai. Do you perform FNAB for gallbladder cancer?
Yeah,
Any
sometimes,
tips?
yeah. For gallbladder cancer, we cannot pass through the lumen of the gallbladder, but if it's embedded into the liver, then we can perform EUS Fna of the gallbladder cancer, or we can target lymph nodes around the gallbladder to get a diagnosis of cancer.
Yeah. So I think the main concern is whether we will cause any leak of the bile if we
Right.
puncture the gallbladder. So just target the solid component and that should be fine.
Yep.
There's a question, how is definition of clinical success or treatment success for pseudocyst drainage? So I think for clinical success is mainly resolution of symptoms and also the resolution of the collection. So on follow-up scan, if the collection is completely gone, then I think we will consider that as a clinical success. And the next question from Hafiz is when you perform drainage of water necrosis, do you always deploy the proximal flange in the working channel of the scope? Yes, so for lamps, for most of my metal stents now with US guided drainage, I would deploy the proximal flange in the channel, even for example, in HGS. So yes, I would perform half under US guidance and then retract the lamps and then deploy the remaining in the channel. Similar for a hepatogastrostomy, and sometimes CDS too. Nakai, do you do the same way?
Yeah, I do the same because if you want to see the black marker in axios, sometimes you have to move the scope and it may cause a migration of the stent. So I will recommend US guided, the intra-channel deployment.
Yeah, I think it's a more stable way to deploy the stent. Actually, there's not much risk of damaging the channel. So this is the standard. Okay, we have a question on the necrosectomy protocol. How frequent? Okay, so this is often a difficult answer. So for me, how do I determine when to do necrosectomy? Usually the drainage is first, and on drainage, we would assess how severe is the solid component. And also clinically, we assess the patient. So if the patient is a febrile staple, but a lot of solid component, then I would arrange a early follow-up OGD, maybe 1 to 2 weeks after drainage and assess how much solid component is inside. If the patient is a bit septic or say the white cell count is persistently high, so after drainage, maybe I would do a follow-up EGD around 3 to 5 days, and then start a necrosectomy earlier. So it depends on the percentage of solid component as well as the clinical condition of the patient. Nakai, what is your practice for necrosectomy?
It's difficult, but if the patient is a septic, then wait a few days and then start necrosectomy, and usually we do 3 days a week.
3 days a week.
3 days a week.
So every 2 days you go in?
Yes.
So, and then you do it until the entire cavity is clean, or?
Yeah, basically we try to remove all the necrotic tissues and to see the pinkish
granulation tissue.
Yeah.
Do you think sometimes it's difficult to do the necrosectomy if we go in too early because the tissue is still sticking together?
Right. So yeah. So you may need a longer procedure time, right? Because it's too sticky. Yeah, but I don't know the answer. Sometimes it's easy even in the early days, but I think if the necrotic tissues include some clots by the bleeding, then I think it's very difficult to remove those tissues because it's very sticky.
Yeah, in those cases, sometimes we would actually change the strategy. So we drainage and then we go in and irrigate, put in a nasocystic catheter, irrigate for a longer time. So we wait a little bit so the tissue, they will digest itself and then becomes easier to remove. So irrigate for some time and then go in maybe 1 or 2 weeks later, and then it becomes easier.
So how do you put the nasogastric tube into the cavity? Do you use an endoscope?
So basically just on a guide wire. So we route to the nose and then put a nasocystic NG tube inside. Okay, another question: if you place plastic stent in one, when is it safe to dilate the tract and do necrosectomy? Which day? Okay. So I think after initial drainage, the tract is still new. So if you want to go inside, I think it's okay if you put, it's okay to go in early. But if the patient, of course, there's a risk of perforation if you go in immediately after the necrosectomy, I mean after the drainage. So when is it safe? Usually maybe 5 to 7 days, I think it's probably okay to dilate. But having said that, sometimes it's still fresh. So if you can wait longer, it's better, but maybe around a week, it should be okay. Bleeding during necrosectomy, endoscopic options versus IRLO. Okay, so for me, I think it really depends on where the bleeding site is. Sometimes it's inside the tract. Sometimes it's in the collection within the necrotic material. With the bleeding can be, if the bleeding is seen during the procedure, then we will try endoscopic first. And if the bleeding is very severe, we will need embolization. Do you have the same practice, Nakai?
Yeah, usually if it's in the tract, then I will use a balloon compression. And if it's within the cavity, and if it's not sparring bleeding, then I just watch and wait, and it just stops.
Yeah, I think so. The most important thing during necrosectomy is not to be too aggressive, because when you remove some of the material, sometimes some blood vessel may be hiding. So if you remove a big chunk, if it's sticking very tightly, so I probably don't try to remove it forcefully. In the tract, sometimes if the balloon, you can compress it for a while. If it doesn't work, then you can put in a metal stent. Then it can compress the vessel. Yeah, and then if that doesn't work, then maybe you need IR. Okay, another question is Mrcp or Ercp should be performed before or after Pfc drainage. So I think the idea for Mrcp or Ercp is to assess if there is any PD leak. For us, if we do Mrcp before drainage, actually is sometimes the collection is so big, they cannot see where it's connecting to the PD. So for us, actually, we would do a CT first. If the collection is there, drain, and then afterwards we can arrange an Mrcp at 4 weeks time after the collection is drained. Nakai, any suggestion?
We do MRI before drainage because we want to know the percentage of the solid material. Sometimes CT cannot.
Oh, CT cannot, yes. Yeah.
Right. So we do MRI and then we ask also Mrcp, but as you mentioned, you cannot clearly see the pancreatic duct most of the time. So after that, after drainage, then we do Mrcp again.
Mhm. Yeah. Okay. Do you remove loosened material only during necrosectomy? So yes, for the necrosectomy, when we insert the scope, then we can see some necrotic material, usually some grayish material. And then for the viable ones, they're usually like yellowish pancreatic tissue or yellowish fat. So we remove the necrotic material with the endoscope. So up to the viable tissue. What is your imaging protocol? So usually we would do a follow-up CT or Mrcp at 4 weeks after the complete necrosectomy. Yeah. Okay. So any other questions, Professor Dong?
Any question? Yeah. So no more question now.
Oh.
So thank you very much.
Thank you.
Professor Nakai and Professor Teoh.
Thank you.
And we have very interesting lectures, and I think that we have learned a lot from both of you. And I would like to say thanks to Professor Teoh and Nakai for your time, and my thanks to AEG and But My Hospital, and also Olympus Company for support us to hold this workshop. And thank you very much again. And in the afternoon, we will have the hands-on training session, and Professor Teoh will join us, right?
Yes, yes.
Yeah, thank you very much.
Okay, thank you.
Thank you.
Thanks so much. Bye, Teoh.
Bye-bye.
Bye-bye.